have contract 513, concept rehab, and Karen will be joining us today and will be presenting on and sharing trends and overviews of what is happening to providers' therapy costs and minute utilizations. So Karen, I will let you take it away.
Thank you, Nathan, and thank you to HPS for letting us have some time with the members today. I am Karen Enderle. I'm the Business Development Director at Concept Rehab, and I'm a speech therapist by background, so therapy is near and dear to my heart. For those of you who may not be familiar with Concept Rehab, we are a Midwest provider of rehabilitation services with over 40 years of industry expertise. And I think what really makes us different is we identify each of our customers' unique pain points, and then we customize solutions to assist them in optimizing both clinical and financial performance. And as the preferred provider for HPS, members are entitled to discounted pricing that's below market average. And at the end of our time together today, I'll share some of those solutions with you. So what I'd like to do today is talk about PDPM. You know, 4 months after we rolled out the biggest payment change in 20 years, COVID hit. All focus pivoted, rightfully so, to mitigating the spread and keeping residents and staff safe. And I do recognize we're not out of the woods yet. I know particularly for HPS members that are in Michigan, you know, we're not quite able to catch our breath, but for those that are, I think we need to look ahead. And with costs during COVID just skyrocketing, now the challenge becomes, where can I cut costs so that I can reinvest those dollars back into the SNF operations, right? So Concept Rehab decided to kind of rewind and review PDPM trends for us both internally and externally in order to support our partners by telling a story and looking ahead. So let's step back in time a minute. Let's go back to September of 2019. If you remember, the SNF pulse points then were RUGs, minute utilization for therapy, what's my PPD, and of course, CMS. Those providers, you know, our providers were laser focused on average minutes per week and per day, right? So some SNFs were more aggressive and minutes increased under RUGs. Your therapy contracts at that time were hinged to a RUG based on a per minute price. Now in the Midwest at that time, we were seeing on average a rate of about 92 cents a minute as being very competitive. If you base that on a per day amount, that 92 cents a minute averaged about $81.85 that was paid to therapy. So those were your therapy costs on average. Now I want you to keep those numbers in mind, the 92 cents and the $81.85 a day, because PDPM took out all of those levers. So let me illustrate it like this. Under RUGs, in an average 120 bed facility that maybe did an average daily skilled census of 15, and this SNF would have been in the Midwest, these were the typical RUG distributions that you would see. So this was pre-PDPM. About 67% of your skilled patients were falling under an ultra high. About 21% were very high. 10% were high, 2% medium, and we really just weren't seeing any lows. Now, if you distribute that census of 15, this is the number of residents on that caseload that would have fallen into each of these categories. Under an ultra high, 720 minutes were delivered per week. Multiply that by the 10 patients, that's 7,200 minutes a week, and so on and so forth for each of these distributions. So in that average 120 bed skilled facility in the Midwest with an average skilled census of 15, the minutes per week prior to PDPM that were being delivered were about 9,263. Divide that by 15 residents, and the average minutes a week were 618. Divide that by 7 days, the average minutes per day were 88.21, so just over 88 minutes a day. So now let's go one step further, and let's take that $81.85 that we determined was average, and let's divide that by the 88.21 minutes, and here's our gut check. We get 92 cents a minute, which is what we were seeing on average in the Midwest prior to PDPM. Now, if you go back to the table here and you multiply 92 minutes by the number of minutes for each RUG group, you get that daily rate. And when we do a weighted average on these, we bounce back to the $81.85. So at Concept Rehab, we spent a solid year preparing for contracting and operating under a new payment system. And based on the recommendations from several consultants that we worked with, we determined that PDPM therapy contracts would really need to mimic those of the new payment model. So it was common to see in these contracts, excuse me, contracts that were based on a percentage of the total CMI or a percentage of the therapy component. Now, depending on the SNF size, the skilled volume, if you were a standalone facility, or if you were a book of business that had multiple locations, your rates may have fallen somewhere on this chart from very competitive, average, or less competitive. There's a lot of factors that went into how competitive your rate might have been. So you can use this chart to compare your rate. Now, if you were paying a percent of the total CMI and your PPD was $550, a very competitive rate might have been 14.5% of the total, and you would have been paying $79.75 a day. 15% was an average percent of total that we were seeing, and that equated to $82.50 a day. And a little less competitive would have been maybe 15.5% of total, which your payment would have been $85.25 a day. Now, if your contract was for a percent of therapy only, we found that those rates varied pretty insignificantly because the per day rate for the percentage of therapy varies very little, maybe from 195 to 207. So depending on the percentage of therapy that you were sitting at, a very competitive percentage might have been 38.5, and your average daily payment per patient would have been $79.70. 40% was kind of average, and that would have been $82.80 per day. And less competitive would have been 41%, 41.5, bringing you up to almost $86 a day. Now, if you were hinged to a per minute rate, keep in mind that that was based on the 88 minutes per day that we found from our typical SNF when we did all of those calculations. So a very competitive per minute might have been 90 cents a minute, and you would have been paying $79.20 a day. Average was 94 cents a minute with a daily rate of $82.72, and on the high end, a little less competitive, might have been 97 cents a minute or $87.07 a day. Most therapy companies, not all, but most said, let's try to keep our therapy minutes the same as what those averages were. Now, we all remember that we were all told by CMS that some SNFs were going to win, some SNFs were going to lose because this was all going to be budget neutral, right? Well, what really happened? October of 2019, everybody did great because every patient on caseload got 3 days of that 3 times the NTA, the non-therapy ancillaries. So your October numbers looked good, but they weren't typical. November, December, everybody still did pretty good. Well, unfortunately, that caught CMS's attention. When CMS completed its initial look back on PDPM, it's no secret what they determined. PDPM thus far has been anything but budget neutral. it actually increased payments to SNFs by about 5%, which equates to $1.7 billion in greater payouts. What else happened? Minutes dropped. Since they were no longer hinged to your payment, the national average of therapy minutes dropped from 91 to 62 minutes a day, going as low as 434 minutes a week. And group and concurrent ballooned overnight. They had been sitting at 1%, and they shot up to 29% combined. We also read in McKnight's that there was immediate decline in therapy staffing minutes the first week of PDPM by about 5.5%. And by the end of March, that decline was up to 14.7%. Now, some of which could have been related to COVID, isolation, and quarantine, but there was also an immediate wage and benefit cuts. Now, I'm happy to say that Concept Rehab opted not to take that step, but there was just complete disruption in our industry. This slide illustrates the significant decrease in therapy minutes from 2018 on the left to September of 2020 on the right. And that dip started right here in September of 2019. And then in March, you can see that that's when the COVID fallout kind of hit. So what does all of this mean to you, the SNF providers? Well, unfortunately, this often occurred without transparency on the rehab provider side. Was it intentional? Maybe. With the payment system not tied to minutes, your rate may have decreased from what it was under RUGs, but your therapy cost per minute could have actually escalated because the minutes dropped, but your rate stayed the same. So let's talk about that for a minute. In this first table here on the left, if you are under PDPM now, or under PDPM, if you're still lucky enough to be getting 625 minutes a day, per resident per week, on average, you're still at a rate of 93 cents a minute, which is the equivalent to the $82.50 a day for your therapy. And remember, that was the average that we found prior to PDPM under RUGs. And to just base this a little bit, we got this total by taking 15% of the CMI, or 40%, 15% of the CMI for therapy, or 40% of the total therapy component. Now, look what happens to your cost per minute as we drop these minutes. Let's say now you're only getting 400 minutes. Your cost per minute now went up to $1.45. I'm certainly not suggesting that you should get more and pay less. Let's be honest, therapy providers still have very high costs as well. We have additional PPE and we have high labor costs. Nothing suppressed our costs. But what I am saying is that if you're getting less, you should be paying less. And you can still get really great outcomes at 500 minutes a week. You can still get treatments on the weekend. But if you're getting 500 minutes instead of 625, you should be paying less. Now, what happened during COVID, to give you a peek into contract therapy's world, is that growth became stagnant. Lots of SNFs were shopping, but nobody was making changes. As you can imagine, no one wanted to bring in a whole new team that could potentially disrupt COVID even greater. There was a large, high scale of notable mergers and acquisitions in the therapy realm. Therapy companies were desperate for growth, and unfortunately, this happened on the backs of providers. Well, Concept Rehab wasn't comfortable operating like that. So we started having conversations with each of our customers. We showed them, just like I've showed you here today, the number of minutes. And we show them that on a per week basis. And we show them what their cost is. And if they need to save on the cost, then the conversation becomes, do you want to look at a different clinical model? Now, I can assure you, across the country, this was not happening. Therapy companies were not being this transparent. So here's where we're seeing rates coming in right now. Remember, with rugs, your costs were predictable. With costs based on a percentage of a total or a therapy, your costs can vary. So many providers are shifting to a flat per diem for skilled PDPM and PDPM-like residents. Now, a word of caution with that, if you are seeing low rates, and I've seen lower than this $62 a day here, you're likely getting less than 430 minutes a week. And that is below CMS's average. And that could come with consequences. I guarantee you the only way to provide services at that low of a rate is to drop the minutes because the therapy wages are not changing. So if we look at some of these pricing methodologies, if you look at a flat rate per day, which seems to be preferable right now, a low range would be 62 to 68. And again, that's likely less than 430 minutes a week. A mid-range would be somewhere between $67 and $75 a day, and a high range would be 75 to 82. And again, let's keep in mind, this is for your average 125 bed facility in the Midwest. If your pricing methodology is a percent of the therapy CMG, a low range would be 29 to 33, again, keeping in mind that your minutes are probably very low. Mid-range would be 34% to 36%, and a little bit higher would be 37 to 40%. And just because we can't forget our long-term side of the house, what we're seeing right now for Part B percentage of the fee schedule, including MPPR, because that's a really important question to ask if you are a SNF provider and you're looking at your therapy contract, is my Part B before or after the MPPR? If it's before, then you are absorbing 100% of that MPPR, the reduction. If it's after, the therapy provider is sharing that burden with you. So right now, a low range is below 70%, a mid-range is 70 to 75%, and a high range would be over 76%. So how can we do this? How can we cut costs and not see poor clinical outcomes and readmissions? Well, this is not a get more and pay less, but let's say we go from, right here, 625 minutes per week to 525. Now remember, we're still hinged to that 93 cents a minute. That was our average. So you've only decreased minutes by 14 a day. And if you're that average SNF with a caseload of 15, remember that was 5,475 annual Medicare days, just a 14-minute difference is a savings of $13 a day, which equates to $71,300 annually. That's a pretty nice number. Now let's look at it a different way. Let's say you were sitting at 625, but let's say your clinical mix is mostly medical management, and that's not likely to have a lot of the clinically complex. And so maybe the minute utilization clinically is appropriate for less. So let's say these patients are now receiving 475 minutes a day. I'm sorry, a week. That equates to 68 minutes a day. I'm sorry. Yes, 68 minutes a day. Those dollars then go down to $19.53 of savings. And that equates to, for the same average facility, $106,000, almost $107,000 a year. Those dollars go right back into operational costs. I mean, that could be 1 or 2 full-time salaries right there. But the key is you as the provider have to evaluate where you're sitting. To determine if there's an opportunity or not, ask yourself, what transparency is your current provider having with you? Ask them questions like, how many minutes are you delivering on average per week? How much group and concurrent are you doing? I would ask them to tell you, or for you to calculate once they give you the minutes per week, what your current cost per minute is. And then I would ask from an accountability level for routine reporting of therapy minutes, because that's what we give our partners. We currently, as a company, average somewhere between 525 to 520 minutes per week. Now, we did see a slight downward shift in that due to COVID. But in some of these discussions we're having with folks that aren't currently partnering with us, we're finding that their cost per minute may have increased anywhere from 10% to 40%. And when you look at a more fair model, in other words, paying less if you're getting less, we can save them anywhere from an average of $8 to $15 per day on the skilled patients. But it's all about being transparent, and it's all about asking the right questions. So I'm hoping that that has shed a little bit of light on what's happening with therapy minutes and what you're paying. And I hope that it has really set you up for success to maybe have conversations with your current providers and to ask some of those questions to see where you are. And then to evaluate your own caseload for complexity and determine, where do those minutes clinically need to fall for good outcomes? And what does that mean as far as cost savings for me? And before we wrap up for today, I did want to introduce you to just some of Concept Rehab's solutions. You know, we've identified, particularly in the last almost 2 years now, that financial optimization, census recovery, staffing collaborations are really the true pain points for our providers and for those that, you know, we have conversations with to potentially become Concept Rehab customers. And it's also really important to partner with someone that has post-acute care expertise and can support you through resources, tools, education, and training. And I wanted to just briefly share some of our skilled solutions. Today, it's so important more than ever that we reduce hospital readmissions because of value-based purchasing and because of containing those costs. And so one of our very important tools that we share with our customers is our PACTA, which is a hospital readmission risk assessment. And it evaluates about 18 different common risks that can send residents back to the hospital. And it drops them into a risk level of low, medium, or high. Once they're in those levels, they're placed in a care pathway with very scripted care. It also allows us to do this assessment before discharge, so we can share what risks may still be inherent for readmission, and we can pass those on down the continuum to the next level of care, hoping that those will be no gaps in care and the resident will not return back to the hospital. We have a PDPM analyzer tool, which is great for modeling the reimbursement that you're going to get. If you're questioning an admission, you can put in all of their diagnoses and characteristics and take a look at what that payment rate is going to be and see if it matches the care that you'll have to deliver. And then, of course, we know that managed care is just proliferating our payer sources right now. And so we work really hard with our customers to evaluate your contracts, look at what the characteristics are, what levels and minutes need to be delivered, and then we work with our teams to make sure you don't end up upside down with your managed care. We certainly can't lose sight of our non-skilled or Part B residents, and so we have a host of screening protocols, of long-term care guides, groups that we put in place so that our therapists, we put these in the hands of our therapists so that they know what to look for in screens and how often to screen, and then step by step for common issues with long-term care, guiding them through what to do. So bed mobility, incontinence, medically complex, COVID long haulers, ADLs, these are all programs that we have in place and are ready to roll out so that we can keep those folks that are aging in place in your facility healthier, longer, and also avoid hospital admissions for them. You know, the MDS intersects with so many operations in a SNF, and it's certainly responsible for whether our reimbursement matches the care we deliver. We're fortunate to have a team of experts on staff that specialize in MDS. They do a great deal of education and training with our customers. They cover things such as GG coding, making sure that your reimbursement under PDPM is accurate. They work with your teams on QRP and value-based purchasing. And they're open access. You can contact them and ask questions like a consultant at any time. Now, a couple times a year, we do offer our MDS Academy of Excellence. We've had wonderful feedback from this. It's 6 live sessions with our specialist, Jennifer Napier, and Tammy Cassidy from TL Cassidy and Associates. It's good for 12 nursing contact hours. It's live, it's interactive, you can ask questions, it's webinar based, and then there's all sorts of performance reporting and tools that go right back to the SNF to help optimize your MDS outcomes, which means optimizing your reimbursement. And then, of course, a very sore spot with skilled nursing facilities right now is certainly census recovery. Once we are at a point where we can open our doors for admissions and where hospitals are doing elective surgeries again, it's going to be really important to have the right partner to support you in that. Therapy should 100% be engaged in your marketing, your media. We can provide market data analytics. We can take a look at your competitors. We can see any hospital in your area and where they're sending folks, even down to the level of diagnosis. If you were looking to build like a niche program to fill a gap in the market, we can do research on that and determine what might work and then help you build that program. We also have experts on staff from marketing, and they have digital strategies and things that they can share. So we really want to support your census recovery, and we have a host of tools, resources, and people to help you do that. And lastly, this is what I think makes us different than the whole sea of providers. Everybody can say they're going to do something, but we back it up by our performance guarantee. So when we begin our partnership, we develop a set of KPIs, and we come up with a time frame that those KPIs will be met. At the end of that time frame, we sit down and determine whether they have. And if we haven't done what we said we were going to do, we drop our rates until such time that we meet those KPIs. And I think that's huge, because that means that everybody from business development to operations is working to deliver on those KPIs from the beginning, from day one. And if not, you pay less. I want to thank you, and I want to thank HPS. I want you to keep in mind that HPS members do receive discounted prices below market average. If you'd like to have a market analysis completed, or you'd like pricing or a proposal, or just to start a conversation, please feel free to reach out to me with my contact information. Thank you all, and happy holidays.